يعطيك العافية. الآن بدنا نكمل الجزء الثاني من كلاس 1 Malocclusion. وصلنا المرة الماضية عند ال Vertical Discrepancies اللي ممكن إحنا نواجهها whenever we treat a patient with a class 1 Malocclusion. واحدة من هاي الشغلات اللي هي ال Anterior Open Bite. So what is Anterior Open Bite? So simply when the posterior teeth bite together, there is still a space between upper and lower incisors, as you can see in this patient. So the patient still has a class 1 incisor relationship, but he has or she has in this photo photograph an anterior open bite where the upper and lower teeth they don't meet, though the posterior teeth are in occlusion. So what is the etiology of the anterior open bite? It could be skeletal, it could be soft tissue, it could be local factor, and habit. So if you can look here, start with the skeletal factor. So simply in these patients, either the maxilla is tipped upward from the anterior teeth upward, or the mandible has a posterior growth rotation that is rotated away from the maxilla. And as you can see, whenever we have a patient with a skeletal anterior open bite, it will involve more teeth. So basically it starts from the premolars and go to the premolars on the other side. In a more severe cases, the patient will bite only on the molars, first or second molar. The second etiology is a soft tissue. As you can see in this patient here, we have minimal anterior open bite, and this is because of the tongue. Tongue is trying to achieve an anterior oral seal, so it kind of move across between the upper and lower incisors to go to the lower lip to achieve anterior oral seal. So if you can look now at the top photo where we have a soft tissue factor as an etiology and the skeletal one. So you can see that the skeletal anterior open bite, it involves more teeth, it is more severe, I mean the number of the anterior open bite, and usually it involves from premolars to the premolars. However, anterior open bite due to the soft tissue and now later due to this local factor, the habit usually they are limited and smaller as well, as you can see in the photograph, and they involving less teeth compared to the anterior open bite due to the skeletal reason. The other etiology is the habit as an etiology for the anterior open bite, and the most common one is the thumb sucking habit. However, thumb sucking habit will most of the time result in a proclination of the upper incisors and retroclination of the lower incisors, and the malocclusion will be class 2 division 1 malocclusion. But because we are talking about the anterior open bite etiology, we mentioned the habit here. Sometimes the local factor as a crowding, the teeth will not reach their full eruption, or they just crowded in a vertical dimension, so they will not have we will not have an overlap between the upper and lowers, and we'll have an anterior open bite. Another local factor is what we call it mouth breather. So patients who has or we call it adenoid face. So patients who has an adenoid face, usually they have adenoid lymph node that is in the upper arch closing the airways. So the patient can't breathe properly from his nose. So all the time the mandible is dropped downward and the patient is breathing from his mouth. So when you drop the mandible, there will be an over eruption of the posterior teeth, and this will result in anterior open bite. However, not all the cases who has a mouth breather and having an adenoid problem will have an anterior open bite as this, because we don't have a strong evidence that patients who breathe from their mouth they will result in anterior open bite, but in some cases it does result in anterior open bite. So the evidence about this kind of etiology is conflicting, and we don't have clear etiological relationship between the mouth breather and the anterior open bite, but it does present in some of the cases. So how to manage the anterior open bite? Well, if we have a habit problem, simply we have to stop the habit, and this is kind of discussed in a separate topic, I mean it's a separate lecture in interceptive orthodontics. But we sometimes, as with this patient, when we have a mild anterior open bite, it's not involving as many teeth as we expected, and a skeletal problem, then we can simply intrude the posterior teeth and encourage the auto-rotation of the mandible. However, you have to avoid extrusion of the upper incisors, because if you extrude the upper incisors, you will end up as this patient with a gum smile, because when the teeth move downward, they will bring the gingiva with them, and that will result in a gum smile. And as well, it's not stable. Extrusion of the upper incisors is very unstable. Once we protrude and extrude the incisors, they would immediately go back where we started. So the option now, when we have a mild, as you can see, a mild skeletal cause of the anterior open bite, as this case here, we can do an intrusion of the posterior teeth that will result in an auto-rotation of the mandible. How we can do the intrusion? Simply, we can use mini screws to intrude the posterior teeth. As you can see here, the patient now having an overbite, but as well, they do not extrude the upper incisors, because as you can see, the amount of the incisal show on smiling is the same. In some textbook, you will find that there's a high ball headgear we use, but in order to have intrusion, you need light continuous force. But the headgear can't be with full time, so using a high ball headgear will result in a strain in the maxillary growth vertically. And in a growing kid, that would result in anterior or auto-rotation of the mandible to close the anterior open bite. When we have a skeletal origin of the anterior open bite, as with this one, orthodontic surgery is the best option to manage this kind of malocclusion, simply by doing osteotomy and impact the posterior maxilla, and then we'll have an anterior auto-rotation of the mandible. This will be covered in a separate topic in the orthodontic surgery lecture, but you know that when we have a skeletal anterior open bite, usually the management is surgery. It's just worth mentioning that anterior open bite is one of the most difficult kind of malocclusion to be treated. And so a lot of cases when anterior open bite, especially when it's a skeletal origin, we send them for surgery. So as we have an anterior open bite, we have a posterior open bite as well. Or sometimes in some textbooks you will find the name as lateral open bite. And the definition is that when anterior teeth meet, there is no occlusion in the posterior teeth. Why is that? Sometimes because of a premature loss of first permanent molar, especially in the lower arch, so the 7 will tip to that space. And as a result, we can have a gap between the upper and lower teeth as a lateral open bite here. And in other cases, lateral posterior lateral open bite is failure for eruption. So basically the teeth, they either erupt into the patient mouth and then stop, as the photo here, or they don't erupt at all, even though the tooth is present. And failure for eruption is one of the most difficult malocclusion to manage, as simply these teeth usually they don't respond very well to the orthodontic movement. Although they are not ankylosed at the beginning of the treatment, but once we start tracting these teeth, they start now to be ankylosed and they don't move. So usually the management of this kind of malocclusion is either to build up the teeth as they are, if we can, or just simply to extract and replace with an implant and a prosthetic teeth, because they will not erupt and they get ankylosed. The other etiology of the posterior open bite, if we have asymmetry in the mandible, and we call it hemimandibular hyperplasia, that basically there would be growth on one side of the condyle more than the other, so the mandible will shift to one side than the other. Now, in hemimandibular or hemicondylar hypertrophy, that the mandible is not only going to the left side, it's also going vertically. So the mandible will grow more in a horizontal and in the vertical relationship compared to the other side, which means that we will have a lateral open bite on the affected side. And by the way, in order not to confuse you about the terminology, now the old terminology is called condylar hyperplasia, in which the condyle is growing more on one side, and now this new classification, which they call it Hemi mandibular hypertrophy, if we have a three-dimensional enlargement of the jaw on one side that is growing downward and to one side as well. So that was about the vertical discrepancies that is happening with the patient in a class 1. So what about the transverse discrepancies? So this is the crossbite. So what is the definition of a crossbite? The crossbite is a discrepancy in the buccolingual relationship of the upper and lower teeth. It's just to know that the reference for when we describe a crossbite is the lower arch, and that's why we have two types of crossbite. The first one is a buccal crossbite, as the photograph on the right, in which the buccal cusp of the lower buccal teeth is biting buccally to the buccal cusp of the upper teeth. And we have a lingual crossbite as the photo on the right side, in which the buccal cusp of the lower jaw biting lingual to the palatal cusp of the upper teeth. So the definition depends on the lower teeth, so you're not going to get confused. You need to think that the lower teeth is the reference if they are buccal to the upper molars, buccal to the buccal cusp of the upper, it's called buccal crossbite, and if they lingual to the upper palatal cusp, they are called lingual crossbite. And whenever we have patients with a crossbite, we have to examine displacement. So what do we mean by displacement? Is when the patient close the teeth together, they will have encounter deflecting contacts. And so if they displace their teeth to the left or right or anteriorly in order to achieve maximum intercuspation. As you can see in the photograph here, the patient in the original photograph, they have a coincident they have a coincident midline, and they are biting cusp to cusp. But this is not a comfortable position for the patient. So what they tend to do is to shift the mandible to one side, either to the right or to the left, which one is easier. So once they shift the mandible, they can achieve maximum intercuspation. And as a result, the midlines will not be coincident anymore. And this is what we call displacement. However, as we said, displacement is not only transverse, could be anterior displacement as well. So if you can see in this video here, when the patient bites, he bites edge to edge. But this is not a comfortable position for him, so he just slides the mandible forward. As we can see in this photo, yes, so the patient is displacing the mandible forward to achieve maximum intercuspation. So what is the etiology of crossbite? Again, whenever we have an etiology, is skeletal, soft tissue, and local factor. So what is the skeletal etiology? The first one is kind of obvious, narrow maxilla. So if you have a small maxilla compared to a bigger mandible, then we will end up with a crossbite, as you can see here. Now, generally speaking, whenever we have a bilateral crossbite on the right and left side, the etiology is skeletal. So we can have a crossbite when we have a small maxilla. And we can have a crossbite as well if we have a normal size maxilla, but this maxilla is sitting posterior compared to the mandible. So the anterior-posterior position of the maxilla can result in a crossbite. So how is that? So if you can look at the figure here in the top, we have the black color represent the maxilla, and maybe this pink color represent the mandible. And as you can see, the maxilla is wider posteriorly compared to the anteriorly, and the mandible is the same. So with the same sizes of the teeth, if we push the maxilla posteriorly or the mandible moved forward, so the wider part of the mandible now is biting or occluding with a narrower part of the maxilla. And as a result, we will have a crossbite. Though the size of the jaws are normal in the upper and lower, the maxilla and the mandible, but there is a problem with the anterior-posterior, and that's the result in a crossbite. So moving the mandible forward or moving the maxilla posteriorly because of biting the wider part of the mandible with the narrower part of the maxilla, that will result in a crossbite. Asymmetry as well, it will result in, due to the condylar hyperplasia, it will result in a posterior overbite on one side, but it will result in a crossbite on the other side because the mandible will be shifted. So that's how the skeletal factors can result in crossbite. So what about the soft tissue? Again, thumb sucking. If the patient's doing thumb sucking, what's going to happen, as all of you know, that the thumb will press the mandible downward. and the tongue will go down as well. So there will not be a force from the tongue on the palatal surface of the upper molars, and it will be only from the cheek that is pushing everything inside or palatally. And as a result, the upper molars will go palatal, and we will end up with a crossbite. What about the local factor as an etiology for the crossbite? Sorry about that. What about the local factor? Sometimes the upper premolars, for example, they will erupt palatally. And this is because simply of the tooth germ or the tooth pod is present there. So that will result in a localized crossbite. Sometimes delayed exfoliation of the primary tooth, so the permanent tooth will go buccal or palatal, and that will result in anterior and posterior crossbite. So what are the types of the crossbite, as we know now the etiology? So crossbite can be anterior crossbite and can be posterior crossbite. Anterior crossbites are the one involving the upper incisors, and this will be discussed when you cover class 3 malocclusion. And now we will discuss the posterior crossbite. So the posterior crossbite is defined as the crossbite involving premolars and molar region, involving one or two teeth or the entire buccal segment. All of these are classified as posterior crossbite. Now, posterior crossbite now can be subdivided into different categories. The first one is a unilateral buccal crossbite with displacement. So, if you can look at this patient here, the patient in the bottom photo, she has a crossbite on the left side. But does that mean that the maxilla is smaller on the left compared to the mandible only on the left side? No. The maxilla is smaller than the mandible on the right and on the left, as we can see in the top photograph. But when the patient bites, he's not feeling comfortable, so that's why he's shifting the mandible to the left side. So we call this kind unilateral because it's only on one side, buccal because we know now it's a buccal crossbite because the buccal cusp of the lower is occluding buccal to the upper teeth with displacement to the left. Now this is a very important way to describe crossbite, because if you say that we have a crossbite on the left side only, that does not tell me that there is a displacement or not. So whenever you have a crossbite like this, you have to describe it as unilateral buccal crossbite with displacement to the left. The other type of the crossbite is unilateral buccal crossbite without a displacement. As you can see in the bottom, it could be involving only one tooth, like the lower 6 with the upper 6. However, when the patient is closing, he's not shifting the mandible to one side. And as you can see, the midlines are coincident in this patient here, and there's no shift. So in this case, if we decided to treat this crossbite, we simply treat it only on one side. We don't do expansion. So we're going to discuss this later, how we're going to treat it. However, unilateral buccal crossbite without displacement can involve a whole buccal segment. Now, what is the etiology for that? It could be the path of eruption of the teeth, they tip palatally, or we have a skeletal asymmetry in which the maxilla is narrower than the mandible only on one side. It's very important to diagnose because the unilateral buccal crossbite with or without displacement, because this is going to affect your management. The third category is the bilateral buccal crossbite, which basically we have crossbite on the right side and on the left side buccal. And as we said, usually bilateral buccal crossbite have a skeletal element in their etiology. Not in all the cases, but in most of them. The fourth category is unilateral lingual crossbite. As you can see here, the upper 7, the buccal cusp of the lower 7 occlude palatal to the palatal cusp of the upper 7. So this is a unilateral lingual crossbite. It can involve one tooth and it can involve a whole buccal segment. The last type that we have is bilateral lingual crossbite. Basically, the lower buccal cusp of the lower molars on both sides include palatal to the palatal cusp of the upper molars on both sides. And this is usually due to as well discrepancy between either in the size or on the anterior posterior position. How is that? Maybe a bigger maxilla will result in a bilingual crossbite, or the maxilla is sitting forward and the mandible is sitting backward. So when we have something like this, we have the wider part of the maxilla is colliding with the narrower part of the mandible in an opposite way of a class 3, and that results in a lingual crossbite. So how do we manage crossbites? Well, this depends on the type of the crossbite, and that's why we classified them. So the first one is a unilateral buccal crossbite with displacement. So in this patient, whenever we have displacement, we have to do the expansion on both sides. So when we do the expansion on both sides, the patient can occlude normally and will not have a problem. So let's see this video here.
Of a constricted upper arch.
So if you look at this patient here, it has a constricted upper arch. So basically when the patient bites, that the mandible is not feeling comfortable, and that's why he will shift the occlusion in one side. And that's the displacement. So as you can see here, the midlines are coincident. When the patient closes, the mandible is shifted to one side. In order to treat this one, simply what we need to do is to do expansion on both sides, because the maxilla is narrower in both sides. So expand the mandible, the maxilla, sorry, on both sides. And now when the bite, the patient closes each teeth together, there's no deflecting contact, so he's not having to displace the mandible to one side. So when do we do just simply an expansion? If the amount of the expansion that we need is small, and usually whenever we have a displacement, usually we don't need that amount of expansion, because as we know that most of the crossbite that we see is due to displacement. So once we expand the upper arch, the displacement will disappear and the crossbite. We have to look at the inclination of the upper premolars and see if they are upright or proclined buccally. How is that? You look at the occlusal surface of the maxilla. If you look and see that the premolars and molars are tipped palatally, that means there is no dental-alveolar compensation of the crossbite. And that means we still have a scope for a dental expansion. But if we see that the upper premolars and molars are flared, which means that the buccal cusp is hanging down and the buccal cusp are moved buccally, so that if I decided to do a more expansion for this, they're going to flare even more, and they can have an anterior open bite, so we can't expand the teeth more, and we can go then to another option of treating this patient. But in general, if we don't have, if we have displacement and the palatal and the teeth inclination is vertical, then we can simply treat this patient by expansion. As we can see in the photograph here, in the bottom you can see that the molars and the premolars are upright, or sometimes the premolars are lingually tipped. So this means that we can do expansion easily. Just keep in mind, whenever we do expansion, the palatal cusp in the upper will hang down as a result of the expansion. And when they hang down, the palatal cusp will cause an opening of the bite anteriorly. So if the patient has a reduced overbite at the beginning of the treatment, because of the wedging effect, we will have an anterior open bite because of the expansion. So again, if you do expansion, the palatal cusp will hang down and touch the lower and result in an anterior open bite. So how to do the expansion? There's two types of the appliances that we can use. The first one is to use a quad helix. And as you can see, the quad helix is formed from 4 helices, 1, 2, 3, and 4. And once we expand them, the maxilla will expand. The quad helix advantage that we can control the difference between anterior and posterior expansion. So if we now open the anterior chords, this one will go this way and this one will go this way, so that we can correct the posterior crossbite and doing the expansion only on the molars. But if I want more expansion in the premolars as well, I will open the chords in the posterior and the anterior. So now we do expansion on both the molars and premolars. So as you can see in this video now, during the expansion, fit the quad helix, everything is expanded. As you can see, the palatal cusp, how they are palatally inclined. Expansion, the upper arch is bigger, and now we don't have a crossbite. The other type that we can use is using a removable appliance with an expansion screw. So basically, there's an expansion screw, and you give the patient the key to open the screw. Sorry, this video is from a functional appliance, twin block, and it's just to show you the idea of the expansion using a removable appliance. Just forget about the twin block now. So the patient is giving now the key, and he is opening the expansion screw with the key to do the expansion and to correct the crossbite. So that was a unilateral buccal crossbite with displacement. So what about unilateral buccal crossbite without the displacement, as you can see in this photograph? Now remember, if I do expansion, I can't do expansion on one side of the maxilla without the other, because expansion is the reactionary force. If I decided to expand one side, the reactionary force is the opposite direction, and we will do expansion on the other side. So it's always impossible not to do expansion on both sides. So when we have a crossbite like this, what we can do, or crossbite like this. Now, that's why it's very important to do a proper diagnosis. If I do expansion on this side, I will have a reactionary force to push the buccal teeth on the upper posterior teeth on the other side, which is in this case the upper right side, buccally. Now there's no displacement, which means that pushing the upper buccal teeth buccally will result in a scissor bite on the buccal side, and the crossbite on this side, which is the left side, will be corrected. So we have to be careful when we diagnose the crossbite before we decide the treatment. So how do we manage patients with unilateral buccal crossbite without the displacement? We can do something, we call it cross elastics, and this is done only with fixed appliance. So cross elastics go from the palatal side of the upper molars, and it goes to the buccal side of the lower molars. So that will push the upper posterior teeth outward and the lower posterior teeth inward, and that will help to correct the crossbite, as we can see in this photograph. Bilateral crossbite as well. So as you can see, that bilateral crossbite, buccal crossbite, they usually don't have displacement, because, well, simply buccal crossbite, bilateral buccal crossbite, functionally the patient is normal. He's just biting with the buccal teeth, the posterior teeth in the lower arch, biting buccally with no displacement, with no problem. That leads us that we don't really have to treat patients with bilateral buccal crossbite, because there is simply a risk of treating this kind of malocclusion, that if you do expansion, and again the patient is not committed to the retainer, and we might have a relapse, so the arch will be constricted again. But it will not be constricted to the same degree it used to be, so to the point that we will have a deflective contact and we will have a displacement. So what we did is that we converted the patient who has a bilateral buccal crossbite with no functional problem into one who having a unilateral buccal crossbite with displacement who has a functional problem. So that's why we have to be careful with the bilateral buccal crossbite. So how do we manage buccal crossbite if we decided bilateral crossbite to treat it? The first way is to do surgery to expand the upper arch, because usually this patient has a skeletal element. Or if the buccal, if the upper premolars and molars are tipped palatally, and we can notice that they are tipped palatally in both sides, so that means that I can do dental expansion, because the etiology is dental, and I can do expansion, but I have to keep an eye on the open bite, because expansion will hang down the parietal cusp and result in an open bite. So now we have to consider whether we need to treat bilateral crossbite and how is the treatment. Because the etiology is skeletal, sometimes we go for appliance that achieve skeletal expansion as well. So we have two options so far. The first one is surgery from the beginning. Second one, if the teeth are tipped palatally, to go for expansion dentally, or we can do expansion skeletally using something we call it rapid maxillary expansion, as this photograph. So what is rapid maxillary expansion? We abbreviate that as RME. R for rapid, maxillary, M, and expansion for the E. So RMEs. So the RME is two types, either banded, which is basically banded on the molars and premolars, or it could be bonded, that you have an acrylic cap and it's bonded to the surface of, or glued using glass enamel to the surface of molars and premolars. So why it's called rapid? Because simply in a slow expansion, usual expansion with the URA, we ask the patient to open the screw twice per week. But with rapid maxillary expansion, we ask the patient to open the screw twice daily. So when the patient opened the screw twice daily, and it's a very rigid appliance, it pushed the molars and the premolars outside. Now, so the teeth will be displaced within the socket. And then because it's rapid and the activation is being done every day, twice. Now, the teeth, there's no time for remodeling to take place with bone resorption and bone deposition to allow for the teeth to move. So the force will be transmitted from the teeth into the mid-palatal suture. And if this treatment is done before the age of 50, this will be a soft suture. It's not going to be fused and closed. So we'll have a splitting of the suture, and the maxilla will be expanded skeletally. The amount of the expansion we get with the RME is huge. So as you can see here, the patient did not have a diastema before we started. So now he has a median diastema because of the RME. So this is the whole principle of using an RME. So when you use an RME, the etiology should be skeletal. We should have a bilateral crossbite, and we have to ask the patient to open the expansion screw twice daily. So is what we get stable with RME, is it purely skeletal? The answer, unfortunately, is not. Well, what we get from the expansion using RME, some of it is skeletal, yeah, but as well we get dental tipping and bone bending. So why is tipping? Because we are attached the appliance to the teeth, so they will tip anyway. So there will be a dental movement. And we call it bone bending because the maxilla, what will happen, because we're applying the force quickly, the maxilla will just bend outside. And then after we finish the treatment, the bone tend to tip inside again, and the tipping of the teeth tend to go back again. So when we do expansion, with RME, it will relapse by at least 30 to 40%. And that's why when we do RME expansion, we overcorrect it, because we need to allow room for the relapse to happen. And sometimes what we do is to ask the patient, after we finish expansion, we keep the appliance for 2 to 3 months just to retain what we did. So what are the disadvantages or the side effects of using RME? First of all, it's a bulky appliance. Second, it's sometimes painful because you're asking the patient to open the screw twice. Discomfort for the patient. Patients sometimes can hear the sound of the crack of the maxilla of being opened. Sometimes patient might have a nasal bleeding because of this opening up of the suture. Sometimes root resorption because of the amount of heavy force that we apply every day. The median diastema as well that the patient will develop, and it's a huge median diastema. So the summary, yes, we use RME, but we know that we get some skeletal effect, and we know that there will be a relapse, so that we need to over expand and retain. So what about unilateral lingual crossbite? How we correct this one? Simply by using a cross elastic spot in the opposite direction to move the upper teeth lingually and the lower teeth buccal. And that's happened with whether it's a one tooth or a buccal segment. So we ask the patient to wear the cross elastics, but from the buccal side of the upper to the palatal side or the lingual side of the lower. So by this now we've finished talking about the crossbite, and we move to the last topic that we have about class 1 malocclusion, which is bi-maxillary proclination. So what is bi-maxillary proclination? In this photograph here on the right, it's a normal inclination of the upper and lower incisors, where the interincisal angle is 137. But when the upper and lower incisors are proclined, so the interincisal angle will be reduced, we can see something like this. The upper and lower teeth are pushed forward. So the patient will have slightly increased overjet, even though that he is a class 1 incisors. And sometimes they describe bi-maxillary proclination as a hidden crowding. So basically there is a crowded dentition, but in order to hide this crowding, the teeth tend to procline. And now we will have a well-aligned dentition, but sometimes spacing, but they are proclined, and the patient, they don't like it. as if this patient is, you can see protrusion of the lips, and if you look at you can see that upper and lower lips are sitting far away from the zero meridian line. If you can look intraorally, there's no crowding in the upper arch because the teeth are proclined and we have slight spacing in the lower. So these patients, usually they don't like the appearance of the teeth because they look too proclined. So what we can do, simply extract 4 units in the upper and lower and retract everything backward to achieve retroclination of the upper and lower incisors. As we said here for this patient, 4 premolars were extracted and the teeth are retroclined, and you can see how hair profile is kind of flattened after we did that. And this is here how we started the treatment. And this is hair teeth in where we extracted 4 premolars. Thank you very much for listening. Now, the references for your lecture for today was taken from 3 chapters in your textbook, Introduction to Orthodontics, from Lera Matcha. It's chapter 8, chapter 12, and chapter 13. Please make sure to read all these 3 chapters carefully. Thank you.